Hello everyone, today we are starting with the most important topic of our anatomy, that is head and neck, which has very high weightage in our university examination. Within head and neck, we are starting with the scalp, which is also an important topic asked as in short note in our examination. So starting with scalp, what scalp actually is? Scalp is a soft tissue covering the bony cranial wall. That means जो हमारा cranial cap है उसको cover करने वाला जो soft tissue है वो है scalp. अब हम बात करें अगर एक्सटेंट ऑफ स्कैल्प की, तो इट एक्सटेंड्स इंटीरियरली फ्रॉम द सुप्रा ऑर्बिटल मार्जिन टिल पोस्टीरियरली up to the external occipital protuberance and the superior knuckle line. On each side, it extends till the superior temporal lines. ये था हमारा extent of scalp. अब अगर हम बात करें layers of scalp की, तो scalp में 5 layers होती है. These 5 layers can be remembered by the mnemonic, that is scalp only. S for skin, C for connective tissue, A for aponeurosis, L for loose areolar tissue, and P for pericranium. These are the 5 layers of scalp. Starting with the first layer of the scalp, that is skin. Skin of a scalp is thick and hairy. There are large number of hair follicles that are present in the skin. Along with this, स्किन में होते हैं बहुत सारे sebaceous और sweat glands. So इससे related clinical क्या होगी? That due to presence of large number of sebaceous gland, this is a common site of sebaceous cyst. If we talk about the second layer of scalp, that is the connective tissue, which is actually the superficial fascia of the scalp. This layer actually, connective tissue connects the skin to the aponeurosis. अगर आपको ये नहीं पता है कि एपोन्यूरोसिस क्या होता है, तो एपोन्यूरोसिस इज एक्चुअली फ्लैटेंड टेंडन. This connective tissue layer is actually dense fibrous connective tissue, and this layer of connective tissue is also called as layer of nerves and blood vessels, which is because it has large number of nerves and blood vessels. Clinical related to this connective tissue layer is that blood vessels which are present in this connective tissue are actually adherent to the walls, by their walls to the connective tissue, and if there is injury to the wall, then the vessels are unable to fuse, unable to retract, because they are tightly adherent. So this causes profuse bleeding. So to reduce the profuse bleeding, you have to compress that part of the head to reduce the bleeding. This was the clinical related to this connective tissue. This is the diagram which you have to make for this scalp. Starting with the first layer, that is the skin with hairs. Second layer is the connective tissue that contains large number of blood vessels. Third layer is aponeurosis. Fourth layer is loose areolar tissue. Fifth layer is the pericranium covering the cranial vault. Beneath the cranial vault, there are dura mater, arachnoid matter, and pia mater, in which the dura mater is split into two layers, that is the endosteal layer, that is covering the inner aspect of the cranium, and the meningeal layer that is adherent to the arachnoid matter. So between these two layers there is dural venous sinuses, which are actually connected to the second layer, that is connective tissue layer, via emissary vein. We will talk later about the emissary vein. Now our third layer इज दी एपिक्रेनियल एपोन्यूरोसिस. हम लोग एपिक्रेनियल इसीलिए बोल रहे हैं बिकॉज इट इज़ प्रेजेंट अबव द क्रेनियम, दैट इज़ वाई एपिक्रेनियल एपोन्यूरोसिस. इसको हम लोग गेलिया एपोन्यूराटिका भी बोलते हैं. गेलिया हेयर मीन्स हेलमेट. दिस लेयर इज एक्चुअली फॉर्म बाय द ऑक्सीपिटोफ्रंटालिस मसल एंड इट्स एपोन्यूरोसिस. अगर हम ऑक्सीपिटोफ्रंटालिस मसल की बात करें, सो इट हैज़ एन ऑक्सीपिटल बेली एंड अ फ्रंटल बेली. There are two heads of both of them. So if we talk about the nerve supply of occipital belly, it is posterior auricular branch of facial nerve, and of frontal belly it is temporal branch of facial nerve. Facial nerve is the seventh cranial nerve. Anteriorly, this aponeurosis receives insertion of frontalis muscle, posteriorly of occipitalis, and laterally of temporoparaetalis muscle. Frontalis is actually another name of frontal belly of occipitofrontalis, and occipitalis is another name of occipital belly of occipitofrontalis. The clinical related to this layer is that if there is transverse wound, then it causes gaping. That is, अगर ट्रांसवर्सली एपिक्रेनियल एपोन्यूरोसिस कट हो जाता है तो वो उसमें गैप हो जाता है. क्यों? बिकॉज देयर इज ऑक्सीपिटोफ्रंटालिस मसल विच इज पुलिंग इट एंटीरियरली एंड पोस्टीरियरली. दिस वॉज क्लिनिकल रिलेटेड टू दिस एपिक्रेनियल एपोन्यूरोसिस. Fourth layer is the loose areolar tissue, which is made up of loose areolar connective tissue only. This layer is traversed by a large number of emissary veins, and this layer is called as the dangerous layer of scalp. Why? Because infection or any pus present in this loose areolar tissue layer can reach to dural venous sinus. That is this dural venous sinus can reach to this dural venous sinus, and through this dural venous sinus it can cause thrombosis. That is why this is called as the dangerous layer of scalp. If we talk about the emissary veins are valvulus veins that connect the second layer of scalp to the dural venous sinus. Another clinical related to this layer is the black eye. What happens if there is a injury to your blood vessels, subcutaneous blood vessels via local violence, example fist fighting? Blood in the loose areolar tissue will start collecting, which will track down around the orbit. इसका मतलब है कि वो हमारी ऑर्बिट के अराउंड इकट्ठा होने लग जाता है. वाई दिस हैपन्स? बिकॉज इंटीरियरली द फ्रंटालिस मसल डू नॉट हैव एनी बोनी अटैचमेंट. जो फ्रंटालिस मसल है वो हमारे सबक्यूटेनियस टिश्यू पे ही इंसर्ट होती है, स्किन पे इंसर्ट होती है, एंड इट डज नॉट इंसर्ट ऑन द बोन. सो ब्लड कैन ट्रैक अराउंड द ऑर्बिट एंड दिस विल प्रोड्यूस ब्लैक आई. Posteriorly and laterally there is no effect of this because there is bony attachment of occipitalis muscle and temporoparietalis muscle. Another clinical is safety valve hematoma. If there is fracture of the cranial vault, then this will cause dura and pericranium rupture, and the intracranial hemorrhage will communicate with the loose areolar tissue. So the blood which will not be collected inside the brain and will not cause compression of the brain. Other than this, it will actually come out and track around the eyeball, but it will prevent the cerebral compression, so there are less chances of brain damage. If we talk about the fifth layer is actually periosteum of skull bone. So pericranium is nothing but it is actually the periosteum only. It is loosely attached to the bone but firmly adherent to the sutures. So on the bone it is loosely attached, but in the area of sutures it actually dips in the sutural membrane and tightly adherent to it. And below the suture it continues as the endocranium on inner aspect of the bone. Clinical related to it is cephalhematoma. If there is injury generally in the parietal region, and if there is subpericranial or subperiosteal collection of blood, then what will happen? Bleed will take the shape of the bone concerned. That means कि अगर beneath the pericranium कोई भी अगर bleeding होती है, so जो pericranium है वो bone से loosely attached है but sutures पे tightly attached है, so it will actually form the shape of that bone. That is the cephalhematoma. If we talk about some important points, skin, connective tissue and aponeurosis, that is the first three layers of the scalp are called as the surgical layer of scalp. Why? Because during surgeries these three layers cannot be separated from each other and they combinedly get removed. Secondly, craniotomy incisions are given in the midline. We will discuss it later. And caput succedanum, what it is? This is actually a soft tissue swelling on the part of the skull bone which occurs due to rupture of capillaries during delivery. Now, if we talk about the nerve supply of scalp, scalp is supplied by 20 nerves, each half supplied by the 10 nerves. If we talk how it is explained, in front of the auricle there are 5 nerves, behind the auricle there are 5 nerves. In front of auricle 4 sensory and 1 motor nerve, Behind also 4 sensory and 1 motor nerve. Now let's discuss what are those 4 sensory nerves and motor nerves. The 4 sensory nerves are supratrochlear nerve, supraorbital nerve, zygomaticotemporal nerve and auriculotemporal nerve. And the motor nerve is temporal branch of the facial nerve. Supratrochlear and supraorbital nerves are branches of ophthalmic nerve. Zygomaticotemporal nerve is a branch of maxillary nerve. Auriculotemporal nerve is a branch of mandibular nerve. And these three nerves, ophthalmic nerve, maxillary nerve and mandibular nerve, are actually branches of trigeminal nerve, which is the fifth cranial nerve. If we talk about the posterior half of the scalp, that is behind the auricle, it is also supplied by the 4 sensory and 1 motor nerve. The 4 sensory nerves are the great auricular nerve, the lesser occipital nerve, the greater occipital nerve and the third occipital nerve. And the motor nerve is the posterior auricular branch of facial nerve. The greater auricular nerve is the nerve from the ventral lamina of C2, C3, lesser occipital nerve from the ventral lamina of C2, greater occipital nerve from the dorsal lamina of C2 and third occipital nerve from the dorsal lamina of C3. Talking about the blood supply. In blood supply, you should always remember to mention both the arterial supply as well as the venous drainage. So, if we talk about the arterial supply, same like that of nerve, यहाँ पर भी auricle के आगे और auricle के पीछे. Auricle के आगे there are 3 arteries, which is supratrochlear artery, supraorbital artery and superficial temporal artery. The supratrochlear and supraorbital arteries are branches of ophthalmic artery और ophthalmic artery जो है वो internal carotid artery की branch है. If we talk about the superficial temporal artery, which is a branch of external carotid artery, and behind the auricle there are 2 arteries, posterior auricular artery and occipital artery, which are also the branches of external carotid artery. जब हम external carotid पढ़ेंगे, we will discuss all these arteries there. If we talk about the venous drainage, the supratrochlear vein and the supraorbital vein combine to form an angular vein. This angular vein will then continues as the facial vein. Now here in front of the auricle, the maxillary vein and the superficial temporal vein joins to form retromandibular vein. This retromandibular vein divides into two, that is the anterior division and the posterior division of retromandibular vein. The anterior division of retromandibular vein combined with the facial vein to form common facial vein, which drains into the internal jugular vein, while the posterior division of retromandibular vein combined with the posterior auricular vein to form external jugular vein, which drains directly into the subclavian vein. You can easily remember that behind the auricle this is posterior auricular. Talking about the last part, that is the lymphatic drainage. Anterior part of scalp, the lymph drains into the preauricular or parotid group of lymph nodes, and the posterior part of scalp drain into the mastoid and occipital lymph nodes. Thank you.